Hello everyone, myself Dr. Amit Chakraborty. I am a head and neck cancer specialist at Specialty Surgical Oncology, Mumbai. Today in this video we are going to discuss what are the head and neck cancer treatment options. See, whenever any patients with head and neck cancer comes to us, so what is most important, we first decide what is the site of cancer. Like few patients might have tongue cancer, buccal mucosa cancer, lower jaw, that is alveolar cancer, or cancer of base of tongue, tonsil, upper part of esophagus, larynx, hypopharynx. Based on what site or what organ is involved, the treatment option gets formulated in that way. For most of the head and neck malignancies, in more than 90% of the cases, if the patient is treatable, curable, if we are capable of getting good margin, surgery is considered to be the gold standard test. But what I want to tell you is that the outcome of surgery always depends on the stage at which the patient gets presented. If the patient is treated in early stage, the patient will have good overall survival, good disease-free survival. But if the patient gets treated or operated in advanced stage, the outcome, the overall survival, disease-free survival comparatively reduces. So, suppose if the patient is having early tongue cancer or buccal mucosa cancer, in this particular thing we do surgical excision, don't require major plastic surgical reconstruction. If your tongue is being removed more than 40% or cheek mucosa has been removed extensively, or we need to remove a part of bone of your mandible, then we consider plastic reconstruction in those cases. Sections can be done either by using free radial artery forearm flap, groin-based circumflex iliac flap, or medial sural artery perforator based flap. And when we remove the jawbone, we do reconstruction using free fibula flap. In few cases, we see extensive resection being done, like inner cheek, bone, mandible, then the outer cheek. In those cases, we do reconstruction by using the workhorse flap, that is anterolateral thigh flap. During surgery, what is most important? In any free flap surgery, first 2 to 3 days are important, because that is the time where your anastomosis matures and we regularly check the blood supply to the newly implanted flap. Sometimes we see lesions in larynx, and that too in very early stages. In those cases, we either perform microlaryngeal surgery or we perform radiation or give chemoradiation to them. Is it curable? Yes, it is 100% curable. It is fully treatable. Seen patients, those who treated with radiation or chemoradiation, they don't relapse with the disease years together. Similarly, the base of tongue lesion, tonsil lesion, hypopharyngeal lesion, if they are reached at early stage, nowadays we are performing robotic surgeries for that. But if their stage is locally advanced, stage 3 or beyond that year, we prefer either to downstage the tumor by giving neoadjuvant chemotherapy, and depending on the response or the treatment that has been shown to this treatment, we decide either this patient should be subjected for surgery or further definitive curative radiation chemotherapy, right? And in few cases like thyroid, surgery is always the gold standard treatment, specifically in well differentiated thyroid cancer. We perform total thyroidectomy based on the size of the lesion. If the lesion is less than 2 cm, hemithyroidectomy is the gold standard rule. If it is more than 2, we perform total thyroidectomy with bilateral selective neck dissection. The only one thing which is important during this surgery is to preserve your recurrent laryngeal nerve so that the patient should not have hoarseness of voice in the post-operative period. And the second thing is to prevent hypoparathyroidism leading to hypocalcemia. These are all the minor side effects or sort of complications of surgery. If done in a meticulous way, the chances of it is very, very reduced. So whenever we get very early leukoplakic lesions or erythroplakic lesions, we do laser excisions of the same, right? So surgery remains the gold standard treatment. We get the surgical histopath report in 2 weeks. Based on the histopathological report, we determine whether the patient will require adjuvant radiation or adjuvant chemoradiation. If any patient requires adjuvant treatment, that particular treatment should be initiated before completion of 6 weeks of surgery. If you delay the treatment or don't initiate the treatment up to 6 weeks, then the benefit that you are going to receive for this treatment significantly reduces, and it goes to practically less than 50% the more you delay it. So you have to complete the adjuvant treatment, and what is most important, that it should be initiated properly on time. And second important thing, when you do radiation, you can't take too much gap in between the radiation treatment because of the side effect. I know sometimes the side effects are scary. Meet your surgeon, meet your radiation oncologist, but don't stop the treatment. You need to continue it. So these are the various treatment modalities in head and neck cancer based on the site that is being involved and what we want to treat and what we want to cure. I know you might have different other questions pertaining to head and neck cancer, where you can educate yourself by subscribing to my YouTube video, and you can see different videos and get yourself educated. If you've got any patients pertaining to head and neck cancer, you can write them on the number that is being shown on the screen. We are very happy to collaborate with you, help you out. Thank you very much.